Hey everybody, it's Dr. Eric Balcabs. We're back for another edition of the Thyroid Answers podcast, and today we have another guest. We have Dr. Amie Hornaman. She's known as the Thyroid Fixer, and so I thought it would be it might be interesting to have both of us having a chat about thyroid physiology, because to some degree, some of our thought processes, for those of you who follow both of our websites and some of the stuff that we promote, a lot of I think foundational concepts that we talk about in functional medicine are probably identical. How we may look at thyroid physiology and address it, probably a little bit different. So because I get these questions, I'm sure Amie gets these questions as well. I may have heard somebody says to me, I heard this on this podcast. What's your thought process? What do you think about that? She may get the same things when I say stuff on podcasts, like, I don't agree with that. But we're going to try and have a discussion of how we look at thyroid physiology, maybe where we differ and why we differ in what we think. And then we'll kind of finish that up with some of the, still at the end of the day, the foundational things that we need to consider. If you're going to want to get healthy and get well, this is something I don't think either one of us would have a disagreement on. There's foundational things that everybody's got to do if you want to have a higher level of health. And it really doesn't matter what the disorder, what the disease, what the condition is. These are foundational principles of healthy living that everybody's got to do if you want to have better state and better thyroid physiology. So, Amie, welcome to the Thyroid Answers podcast. How are you today?
Hey, Dr. Eric, I'm excited to be here. I'm glad we finally connected.
All right. So I think maybe the best place to start is to find out and let the listeners know, like, who are you? And some people know, some people may not, but who are you? And tell us a little bit of the backstory of how you got into functional medicine and became the Thyroid Fixer.
Yeah. So, like many of us in this space, I have my own pain to purpose story. I am a hypothyroid patient, Hashimoto's patient, and I didn't know it until my 20s. Now, if I go back many years, there was once a time that I was a bodybuilding competitor, not really the big bodybuilding, but the figure end of things. The more back then, it was much more no steroid use, natural look. But you still had to present your best package, right? You still had to be lean. You had to be muscular. You had to look athletic. You had to stand on stage in a bikini. So you better believe that I busted my butt getting ready for all those shows that I would do, because of course you were being judged in a bikini on stage. So, it was the diet of chicken, fish, broccoli, asparagus, hitting the gym twice a day. And I had done many of these. I couldn't even tell you how many, 10, 15, 20, something like that. There was this one show I was getting ready for. It was the NPC Pittsburgh. For those of you who do compete, you're going to go, oh yeah, that's a big one, right? That's a big show. And, of course I work with a coach. We all need a coach to get ready for things, because you don't want to think for yourself and overthink it. So I had to report my weight every week, right? So I have my regimen. I'm doing all my regimen, and I get on the scale and it's 10 pounds heavier. I'm like, wait a minute. Physiologically, that doesn't make sense, because if you look at what I'm eating, whether you believe in calories in, calories out or not, when you look at what I'm eating, does not make sense that scale would go up. So what do? I do what we all do. I ate less and I exercised more. Probably not the best idea, but you try whatever you want. You got to try to get that scale to move. So I get back on the scale another week later. Now it's up 20 pounds. By the end of the first month that I was doing this, I was up 25 pounds. After that, I stopped getting on the scale. I didn't even want to know. So what I did is what we all do. I went to my doctor and I explained to him. Now, back then, no knowledge of functional medicine. I was not in this space. I knew basic nutrition from my competing. That's it. And I went to my doctor and I said what was going on. And I don't even know what tests they did. I would love to know. I would love to go back and see the testing that they, because we all know it probably was TSH only. And they tell me everything's normal, you're fine. I go to 5 other doctors, so a total of 6 doctors, all told me to eat less, exercise more. It's all in your head. This is just part of getting older. I was in my 20s. And I was really frustrated. I mean, I remember being devastated, frustrated, wearing sweatshirts at the gym. I had shame. I was depressed. I thought, what's going to happen to me? People are judging me. And then I go to doctor number 7, who actually diagnosed me. Now, this is an endocrinologist, but she at least diagnosed me. And I left her office with a pill, which was T4. And at that time, I was super excited. I was like, yeah, I have a diagnosis. I have a pill. Everything's going to be fine now. I'm good. Well, 5 months later, it wasn't fine because it did nothing. I didn't lose a pound. I didn't feel better. Not another hair was grown on my head from the hair that I lost. And I started researching, what to do. Integrative, functional. I kept hearing the name of this integrative practitioner over and over again. And, sometimes you hear somebody's name multiple times. You're like, I better listen to the universe, right? It's telling me to contact him. So I reach out to him and he changed my life. He became my mentor, brought me into this space. And what he did was he listened to me. He sat down with me for an hour and a half. We talked about my lifestyle. We talked about my eating. We talked about my supplements. He did all of the testing that should be done to check my thyroid function. And he changed up my medication, my thyroid hormone replacement. Now, there was some insulin resistance there that he uncovered that we know is very much tied to hypothyroidism. You and I talk about that all the time. So we were doing all of the things to really support my body, and I got better. And that was really my awakening to go, here's little me in Pittsburgh, PA, being misdiagnosed 6 times. How many other people are out there? How many other women are out there? Because we know it hits women the most. How many other women are out there that are frustrated? They're giving up. They're giving up after doctor number 2. They're believing doctor number 3 that it's all in their head. And how many need this kind of help? So that's really what just catapulted me into this functional medicine space, specializing in the thyroid.
All right. So I got a couple questions that maybe listeners are having at the same time as I'm listening to that. So before you got into competition, were you overweight? Did you have health issues? Were you having signs and symptoms of hypothyroidism before you got into this competition? Or was it something that developed as you were doing this thing?
That's a great question. So, yes, I don't talk about this often, but I do talk about it. I was a fat kid. I was a chubby child. Now, when I look back, a lot of it was my family's behavior. We have diabetes in my family, insulin resistance in my family. And, it was just standard protocol that you had French vanilla ice cream and Lorna Doone cookies after dinner every single night. And, reward food was a reward. Food was something that we look forward to. So it really wasn't until I was in high school that I became active. I started actually going to the gym at a very young age, taking care of myself because I didn't like this extra weight that I was carrying around so young. Now, when I started working out, the weight dropped. So through high school, through college, no health problems, no weight problems at all. Cycles were normal, no signs of PCOS, anything like that. It really wasn't until I hit my 20s that everything started happening. So, looking back at that, and I think you're going to go down this road, the extreme dieting, the extreme exercise absolutely put a stress on my body that flipped on that Hashimoto switch.
Yeah, because if there's, standard American lifestyle, and just look around, 60% of the US population is overweight or obese. So the way we live currently there's a tendency to be overweight and fat. What's interesting is in today's world, I think more people say they're exercising and working out than probably ever. And yet we still have more obesity, which is a whole nother discussion maybe. But let me keep going on that. Mm-hmm. So when all of this started happening, you're doing more extreme dieting, more extreme fitness, and somebody might say, well, exercise is good, isn't it? But one of the things that I talk about, I'm sure you talk about it, exercise is fantastic. Recovery is what makes exercise really fantastic. If you don't recover, then you're just creating excessive stress on the physiology. And, my story is similar but different, but just too much stuff and too little recovery, and that creates issues. But we tried T4. The time that you tried T4, Synthroid, levothyroxine, whatever it was, didn't really work out too well. You went to a functionally based doctor, and I think you said that you started working on the lifestyle factors. I call them fitness factors, lifestyle factors, whatever you call them, and you started seeing improvement. But I thought I heard you say that you also did a change in the medication. So what was the change medication wise that seemed to help?
Yeah, we went to Armor. We switched over to Armor, and just that change alone seemed to really move the needle, and my body responded to it for a short period of time. I can't remember how long. Again, I would love to go back and look at all my records, knowing what I know now. But I want to say it was less than a year. And of course, that changeover from T4 only, which we know rarely works, that change over to giving me a little bit of T3, I think that helped my system and started at least shedding the weight. I was feeling better. But then I hit that brick wall again. And even increasing the Armor, that wasn't enough to move it. So after that, again, I went back to him and he's like, let's just try T3 only. Let's see if maybe you don't convert, because I had an elevated reverse T3 on the Armor. And he said, let's just try T3 only. So we did almost an experiment where I would do T3 only and I would feel fine. I would feel better. Hypo symptoms gone. Then he would say, okay, just let's add in 25 micrograms of T4, just a little bit. And I would put that in. And after a week, the scale started going up. I became depressed, lethargic, pull it back out, got better, put it back in, got worse. And we did that a couple times. And I've experimented with myself over the years too, even not working with him anymore, just kind of treating myself. Yeah, it just doesn't work for me. So now I'm a rarity. I want to say that. I'm sure you've mentioned this before to your audience. There's not many people that are T3 only candidates that just flat out, you don't convert. But there are some. I do have some patients that are. And when you try to add that T4 back in, it's just a no-go.
So, yeah, I think that there's, and you may or may not agree, but I think there's this concept that if you take T4 and your reverse T3 is high and your free T3 are low, that you're a non-converter. That's the term that's out there that people say, well, I think I'm a non-converter. And I think some people think that it is that either the physiology, they have a genetic polymorphism. And I'll ask you, because you may know that already if you are or aren't. Do you have a genetic polymorphism that prevents you from converting T4 to T3 effectively or efficiently? I think for the vast majority, there's the idenase 2 polymorphisms are out there. I don't think it's the primary cause. And I think you could probably agree with that piece of it. The next part of that would be, is the lack of being able to convert T4 to T3 an adaptive process, or is it broken physiology, right? So if you say, I do better on T3, then we have to ask the question, okay, but why is this person doing better on T3? Is it a genetic polymorphism? Is there something that caused that gene, that deiodinase 2 converting enzyme, to become defective? And I don't know of anything that causes that gene to become defective. Or is it being restricted or inhibited in some way that's reducing the conversion? So what do you think, from your perspective, is the reason that you went from somebody who obviously could convert T4 to T3? That's where we kind of started. We're like, hey, I was pretty good in high school and college converting. But then when I started doing this extreme stuff and really stressing my system out, then I wasn't converting as well. And that was causing me to gain weight. So what do you think it was in your situation? Do you have like a deiodinase 2 polymorphism? Do you think that something is preventing that deiodinase 2 from working? Like, what do you think is the scenario that would cause you to not be able to convert that T4 to T3 and not feel well on T4 only?
Yeah. So a couple different answers for that. So number one, I don't know whether I have the polymorphism. I've always wondered that. I've always suspected that, because when I add in T4, it's not like my reverse shoots up. And we all know too, and it's worth mentioning. You and I know that people do, and this is where we definitely agree, that people do tend to look at their numbers and get hyper focused on a number, right? So I'll even have patients, they're like, well, my reverse T3 is a 16, so we better change my medication. And it's like, let's step back and look at the things that drive up reverse T3, because it might not be a change of medication. It might be that we need to address the lifestyle and the things, the nutrient deficiencies, the insulin resistance, the whatever that's going to drive up that reverse T3. But in my case, I checked all those boxes, and I've done that experiment over and over again, where it's like, there's nothing in my body that should be driving up reverse T3. Overall, I feel really good. Like right now, I'm optimized. I'm fine. I'm a stable weight. I don't have to crash diet. I don't even do cardio anymore. I just do weight training. You know, my heart rate gets up with heavy weights. That's all I do. I don't kill myself anymore. And yet still, when I add in that T4, I go hypo. So it's not even that it's pushing up my reverse T3. I'll go hypo before that reverse T3 even has a chance to climb. So I would suspect in my case that I do have the polymorphism, but I definitely wanted to address the people that get hyper focused on the reverse T3, because lifestyle is a huge component. So I do think that I did damage. So if it's not the polymorphism, then it was definitely that time of my life of just, I mean, we did cardio twice a day back then. I mean, sometimes you were doing 45 minutes to an hour of cardio twice a day. That is stupid. I mean, for all y'all listening, don't do that, because, you know, the extreme dieting, the calorie restriction, the extreme exercise, I mean, come on, that absolutely takes a toll on your body. And I was not the typical competitor that walked around like a stick figure. You know, some of these girls, all they had to do is do some cardio and step on stage. I had to bust my ass every single time. So it was definitely, I had to put in more effort, which I believe resulted in some kind of metabolic damage. So maybe I did damage some system in there that we don't even know about, that, you know, made that D2 enzyme go crazy, not work anymore, whatever.
Yeah. And so it's possible. I mean, I think, are there a lot of people walking around with polymorphisms? I don't think we have good numbers on those things. So, but I think when people come to me and they say I'm a non-converter, I usually say, well, it's likely not the case, because you wouldn't be the person you are. You couldn't be an intelligent Amie Hornaman doing the things you're doing if you had a complete non-conversion issue going on. You wouldn't have developed appropriately. So that means there's some type of epigenetic influence that's potentially affecting the deiodinase 2 polymorphism. We know chronic low-grade inflammation plays a role. Excessive stress can play a role. There's something that's probably having an impact on cell physiology.
Yeah.
And one of the things you said with the armor, and I think this is a good, before I kind of jump into something else, I think this is a good thing to talk with people about. And you said when you were taking armor, and I'm guessing as your dose went up, your reverse T3 goes up. So I would anticipate that to go up, because the more T3 you're taking, the more you're supporting the tissues, the more you're essentially down regulating the need for more T4 to T3 conversion. Right. Mm-hmm. So I wouldn't find that hard to believe. If I'm taking plenty of T3, why do I need more T4 to T3 conversion? Now, there is the discussion that when in a hyperthyroid state, we actually get more T4 to T3 conversion. And I think there's a good reason for that. But I think in general, when you see somebody who's trying to find that magical mix of T4 and T3, but they keep ratcheting up the T3, it's not hard to imagine that their reverse T3 is going to go up as well, because they're trying to saturate tissues. Mm-hmm. But let's talk about thyroid physiology from your perspective. I'll give you mine, and then I want to kind of get to yours. I think to some degree, we look at thyroid physiology from a gland perspective and a bloodstream perspective, and I think that's problematic. This is part of the problem with the allopathic model is we just think that if we just put enough T4 into the system, it's going to get into the cells, it's going to convert to T3. And really the opposite of that is true. If you put too much T4 into the system, it actually reduces the iodinase 2 conversion. You get ubiquination, you actually get a reduced conversion. Do I think medicine actually knew that? Sure. That's probably why they stopped looking at T3, free T3, reverse T3 as they were doing it, because I think they started to use reverse T3 early on to say, we need to we'll use this as an indication if we're giving too much. And then they couldn't make sense of it. Like the patient doesn't feel better and they still have this number. What's going on? And I think that's the piece they didn't really understand is the cell piece of it. So part one is what the gland makes. Part two is what's in the bloodstream. Part three is what is inside the cell and what the cells do with that hormone that's inside the cell. And if you had Dr. Bianco on your podcast, I've had multiple discussions with him, great podcasts with him. I agree with some of the things he says, but I also disagree with some of the things he says, and that's okay. But he's really an allopathic physician looking at it differently. So I love the idea that he's talking about the importance of T3. But I think there's still some pieces from a cell perspective that maybe he does or doesn't agree with from my perspective. But from your perspective, when you're thinking about thyroid physiology, are you focused at each one of those? Or do you think, are you more along the line of what they're talking about in allopathic medicine? Like, hey, as long as we put enough T4, and maybe in this situation, as long as we put enough T3 in the bloodstream, it's got to work.
No, I agree with you. I see too many people coming in on large amounts of T4. And, you and I both see it. The typical person, they start on 88 and then they go to 112 and 125 now or 188 and 200. I mean, just their doctors just keep dumping more and more and more T4 on them because maybe their TSH is still high, but most likely that TSH has come down even on T4 treatment, but the person doesn't feel good. So the allopathic doctor's answer is to give them more T4. And I 100% agree that causes nothing but a shutdown of the patient's own production of T3, and it can obviously increase reverse T3. So my take is to do both. Yes, I believe in thyroid hormone replacement. So I think that if you have someone on a large amount of T4, they come in, their free T3 is low, they have all of the symptoms, they possibly have an elevated reverse T3. Let's lower that T4 dose. Let's take that down a notch. Let's add in some T3 so we can balance the system out. And at the same time, so I always talk about both and, because I never want my patients, I don't want my audience, my listeners to ever think it's just about thyroid medication. And I've been pounding this a lot more lately too. You can't lose weight. It's not about putting more thyroid medication on. It's about looking at what is the cause. So you still have to look at all the other factors. Is there insulin resistance? Is there an imbalance of sex hormones that need to be addressed? Is there estrogen dominance, low testosterone, inflammation? The person's walking around with high amounts of stress. Their blood sugar is totally imbalanced. Their cortisol is out of whack. I mean, we can talk about that because I'm going to ask you that on my podcast because I know we have the same concept of adrenal fatigue and how too many people think that they have it, but they don't. But it's just, you have to look at all the factors of a person. Yes, I believe in thyroid hormone replacement. I believe in getting that at the right dose. But what I try to train my patients not to do is to look at a number. The numbers are great when we first start. It's fantastic. You come in, you're on T4 only, your free T3 is a 2.3, your reverse is an 18. Duh. Yeah, we have to do some changes. We have to lower that T4. Let's add in a little bit T3. You're going to feel better. Your symptoms are going to be relieved. And that's going to help both of us as we're working on all of those other factors, as we're changing your diet to lower the insulin, as we're tweaking your hormones, as we're doing all the things, addressing nutrient deficiencies. And there might be some changes in thyroid medication as well as we go along. But the last thing I want is the patient who comes in and goes, well, you talk about free T3 optimal being like a 3 or above or the upper quadrant of the range, and I'm not there. And I go, well, how do you feel? Well, I feel great. I'm losing weight and I have energy and I'm this and that, but my free T3 is only a 2.8. I go, well, then what do you care? What do you care? You feel good. Your symptoms are relieved. We're not going to chase a number and give you more T3 just to try to hit a number. We're trying to give you a better life. So I think it's, my take on it is let's blend everything together. I don't want the reverse high. I don't want your cells being blocked. I want that T3 in doing its job, but it's not about dumping more and more on. It's about doing everything.
So I'm guessing, because I would look at the low T3 state and say, all right, this is more of an adaptive downregulation, and we need to address what's driving this, right? I don't look at it as broken physiology at the cell level. If reverse T3 is elevated, T3 is low, I'm saying, hey, this is likely some type of adaptive response to excessive cell stress. What is it? Look at their caloric intake. Look at all the things that, all the things I think we would agree on is there a gut inflammation? Is there inflammation systemically? Is this person in an emotional stress and trauma? Do they overtrain? Do they undercalorize? Do they not get a sufficient level of protein and macros? That's where we need to do it.
Mm-hmm.
I think it sounds like, and you can correct me if I'm wrong, because I don't want to put this in the wrong, say this wrong, but you're looking at that person, and I would do the same thing from a thyroid hormone perspective. If I think they're overloaded in T4, then I'm telling them, hey, we got to talk to your prescribing physician. We got to get the dose reduced, because too much T4 is going to be problematic for converting T3, and driving TSH too low is going to potentially be massively problematic for getting more T3 in the system. It sounds like where you might be inclined, where I may be inclined to say, hey, let's let that TSH go up, because typically the thyroid gland only generates about 5 micrograms of T3, but in states when there's poor conversion peripherally, the thyroid gland can increase the production of T3 to 10 micrograms or even more based on poor conversion. So I want the TSH to be higher in those situations so that I'm driving more production and more help from the thyroid gland. It sounds like what you're trying to do is say, we're going to try and support, we're just going to give you the T3, and hopefully that's going to make you feel a little bit better, and then work on the process. Is that fair?
Yeah, and definitely we still want to drive down the reverse T3. So we're driving down that reverse T3 to take you out of that survival mode by lowering the T4 and giving a little bit of T3, because we know both of those changes will result in a lower reverse T3, especially if the person is doing all the things and changing the things that can drive up reverse T3. And then at the same time, do I want to see that free T3 come up? Sure. And, I think you would agree too, Eric, it's where the person is in their thyroid journey too. So if they're a thyroidectomy patient, I mean, that's a no-brainer. There's no thyroidectomy patient that's going to do well on T4 only. It doesn't matter. You just took out the gland that produced T4 and T3, and then you give them T4 only and expect them to be okay. No, that's not going to work. Or if they're in the latter stages of Hashimoto's, where there's basically nothing left of their thyroid gland, then I absolutely believe let's give you that thyroid hormone that your gland is just no longer producing, or no longer producing well in the proper amounts. Let's give that, because just like we would give a type 2 diabetic whose pancreas is shot, we give them insulin, because if we don't, catastrophic events will happen. On a lesser scale, let's give that person the thyroid hormone that's no longer being produced. But again, it's at the same time as doing everything else.
What's appropriate in those situations? Because if we think about what a thyroid gland would make if it was there and it's gone or it's atrophied, how much T3 did somebody need in that situation? Like, do they need 5 micrograms? Do they need 10, 15, 20, 25, 30? Because what I see for a lot of people is the T3 is like crack. They start on like 5, and then they plateau, and then they need 10, and then they need 15, and then they need 20. And before you know it, they're in no man's or no woman's land with medication. So I agree. If there's no thyroid gland, there's a certain amount of T3 that's made by the thyroid gland, right? And so that may be a case that they need some. Could they have atrophy of their gland and it doesn't function? Yeah. But I also see, and you must see this, even with people that have had thyroidectomies, even with people that have told their thyroid gland is shot and it doesn't function well, when you're working on foundational principles and addressing those things, it is not unusual that a person needs less and less thyroid hormone. And in my patient base, many of them wind up on no thyroid medication at all, even though they've been told they had an atrophied gland. And even I've got a client, I talked to her actually last week, who had thyroidectomy, and on her last checkup, half of that thyroid gland had grown back and she's on no medication anymore. So what is going on? I think when we learned that I think we were taught, I'm getting old, so maybe I forgot, but I think we were told that the thyroid gland can't regenerate. And I don't believe that. I just see it every day that the thyroid gland can respond. I think the reason we don't see it in allopathic medicine is because nobody's really doing anything to address why there's thyroiditis to begin with. But in a functional space, if we're truly doing functional medicine and we're addressing those root issues, absolutely. Do we see a thyroid gland that couldn't make thyroid hormone now start to respond? But we have to be careful, because if we're suppressing TSH with T4 and maybe T3 supplementation, or T3 only possibly, and we keep TSH low, there's no chance that that thyroid gland has the ability to regenerate, because we're providing a lot of what we got. So it doesn't mean that somebody's approach, and for the listener, if you're taking T4 and you feel awesome, I don't think either one of us cares. If you're taking T4 and T3 and you feel awesome, I don't think either one of us cares. If you're on T3 only and you feel awesome and function awesome, I don't think either one of us cares. I don't care what diet you use. I don't care what support you use. My concern is that if you're taking a medication or two or three or supplements and you still don't feel and function well, you're not getting to the root issues. And so that at the end of the day, it's about the client, it's about the patient, whatever makes them feel and function well, and based on what their goals and motivations are, that's what they should do. But that becomes that's my concern with the T3 is, where do you start and where do you say, okay, we've given you what you should be making from this gland. Are you giving more than that? And how much more? And at what point do you start to say, I can give you more that might temporarily make you feel good, but it's going to be contraindicated to actually restore health to your thyroid gland. And maybe you don't feel that it's contraindicated, or it could be problematic. But where do you start? When do you think it's too much?
Oh yeah, no, I've said those words to people actually just this week. So, one of the biggest questions I could ask is, what dose of T3 is, normal, like standard? I'm like, there isn't one, because I can show you someone who is totally rocking their life and optimized at 5 micrograms, at 10 micrograms, 5 twice a day. And I can show you somebody that needed more, that we legit had to keep climbing. But to your point, there is that point at which you go, I can give you more, but at some point we need to figure out why you're, let's say, not losing weight. So that's the typical one, right? The person that comes in, well, I'm not losing weight. It must be, I must need more thyroid hormone. I want to go up in my T3. I'm like, well, we can go up in the T3, but here's the thing. It's only going to temporarily help you. And we need to get to the root of why you're not losing weight. And, there's been so much going on in the last few years that, from stress to toxins to whatever, that's playing a huge role. And I'm seeing that permeate my patients, that they're hitting these roadblocks, some of them, and they want more thyroid hormone, which that's why I've been talking a lot more about the other things involved, because I don't want to train a bunch of people to think it's just all about thyroid hormone. Again, it's the balance. It is important. And I don't have a problem increasing T3 while working with someone to really kind of get to that sweet spot. And that's where most people get. Most people, you find that jiving sweet spot where everything is just flowing. They feel like, okay, finally, all those symptoms I've been dealing with for 20 years are relieved. I'm feeling better. I changed my lifestyle. I'm eating better. Yes, I'm supporting my body with nutrients, with the iodine, with the vitamin D, with the mag, whatever. And at the same time, I feel like I'm finally on that right dose of thyroid hormone replacement that is now supporting me. And of course, we track them and we make little tweaks and changes here and there throughout. But it's all about finding that sweet spot. But to answer your question, there's no dose that I say, well, you better get to XYZ in order to get optimized, because that's not the case. It's all about that personalized medicine, and every individual is so unique, and you have to work with that individual's physiology to find what is going to work for them in their body.
So, and I guess that's where maybe there's some differences in thought process. I guess I don't know what optimized means, right? And so if you use that term a lot, what does that mean? Does that mean I'm optimizing their blood levels? Does it mean I'm optimizing their physiology? Because to me, the way I look at it, if the thyroid gland typically only makes about 5 to 10 micrograms per day, why would I need, and I'll let you do that, because this is, why would I need more than 5 to 10 micrograms to feel optimal if that's all the thyroid gland would typically make in a given situation? Because you're making about 30 micrograms per day, but I see people coming to me who are on significantly more than that, significantly more T3 only, significant amounts of T4 and T3, high levels of compound, whatever, but they're taking way more thyroid medication, T4, than their body would make in a given day. They're taking more T3 than their body would make in a given day. They're definitely taking more than the thyroid gland would make. So why do you think people might need, or what goes through your mind when you get somebody to 5 or 10 micrograms and now they're saying, hey, that worked for a while, but it's not working anymore? What are you thinking?
So now, and you're right. First, let me answer, what is optimized? It's about the person. It's about, at the end of the day, just really getting them back to feeling like themselves again. Because as you know, I mean, that's the biggest thing that we hear from these people. They don't even recognize themselves. They don't feel like themselves. A patient sent me yesterday, and we're only 2 months into working together. She sent me a picture of her face before and a picture now, even just 2 months in, and the swelling and the poofiness, that typical thyroid poofy face, moon face that she was dealing with for years. Just, I mean, it went down. She looks like herself. She's bright-eyed now. So that is optimized. It's getting through the day. It's this patient, we talked the other day. She said, for the first time, she runs her own business and she counsels people. So she has to be on point. She testifies in forensic trials. She has to be on point at a federal level. And she's like, for the first time, I'm not having to take a nap. I'm not, reaching for my words. I can remember things. I can speak more fluidly. So she's noticing a full change in all these different aspects, from her appearance to her brain function to her energy level. And you can't argue with that when you talk about optimization. Now, is it just thyroid medication that's doing that? No, of course not. We're treating her low hormone function. We're addressing her insulin resistance. We're addressing all the things at the same time. That's why I always say both and. But to answer your question now, what do we do when someone needs more? I don't have a problem giving more. Why do they need more? That's where I'm just going to flat out say, I don't know. I mean, there's been some people where, okay, take me, for example, everything's on point. I can't tell you one thing that is off. Of course, I test myself with all the same things that we look at in our patients. I've done a GI map. I've done a Dutch test. I've done the cortisol panel. I've done all the blood work. My liver enzymes are fine. I don't have fatty liver. My insulin's great. I eat perfectly. It's like right now, I think I am just in that perfect optimized state, optimization land. And, I need what I need for T3. And if you pull it, oh gosh, I've tried that. I tried that on myself. I tried, just for giggles, let me just take out a little bit of my T3 medication. Let's just see what happens. Oh my God. It was the worst 2 weeks of my life. El Russ and I have talked about this too, because we'll all experiment on ourselves, right? As thyroid patients, so we can bring it back to the masses. And no, I mean, I just can't. And okay, yeah, you could argue that if I fought through it, but I don't want to fight through another 20-pound weight gain. I don't want to live my life miserable for another 2 months as I try to balance my physiology. This is what works for me. And so that's kind of where I try to find that space for my patients is, where's that perfect blend? As we're working on all the things, where do we have to take your thyroid hormone replacement to get, your numbers pretty close to optimal, what we call in functional medicine optimal. But at the same time, your body, how's your body? How's your body responding? How's your lifestyle? How's your sleep? How's your stress? How's your insulin? How's your cortisol? How's your sex hormones? How are all those things too? And then when we blend those things together, then they just find that sweet spot. So I don't know if I even answered your question. I think the big thing is, I don't know why people need more. I don't know. They just do. And it works anecdotally. And this is the kind of the crazy thing. So I'm spinning off again. This is the kind of crazy thing that I love, actually, is that you have your patients and anecdotal stories out the wazoo that you can be like, no, I took this person off of thyroid medication. They're rocking life. I dropped the thyroid med on this person. They're amazing. You know, we looked at their cells. We fixed their cells. Amazing. And then anecdotally, I have my people over here where I'm like, I changed their thyroid medication. I tweaked them up a little bit in T3 and did all the things, and they're amazing. It's we both have these anecdotal stories that it's like, you can't argue with either of them. Everybody's living their best life. It's just that different approach that we talked about in the beginning.
Yeah, and I think it depends on what the end goal of for the person and what they want to put into a process. If the goal, if somebody says to me, I don't want to have to be on thyroid medication, then I'm like, look, I don't know that that's a reality yet, but if we can address the causes of what's driving thyroiditis, what's reducing the conversion, then your thyroid gland can start to regenerate, make more thyroid hormone, depending on how bad it was damaged. You may be able to do that. You may need less. It should convert better. And in the long run, you may not need a medication at all, but that's not, I usually tell people, we don't know if that's a possibility, but the goal should be, we want to have you take the least amount of thyroid hormone replacement that you need and actually have it function close to the way it should be functioning. And that's what I would call more optimization, right? And so I don't think it's different, but I might have somebody who says, listen, I don't want to do the work that goes into it. Well, then you're probably going to feel better with some T3, at least in the short run. I will say this, for the clients that I've worked with that have come to me on T3 only and not feeling well, getting them back to normal many times is like putting somebody in rehab, because two things have happened. One is you've become dependent on the amount of T3. You've essentially shut off the gland. There's not enough T4 being generated. And as you go down on T3, you have less of the active hormone, which has a short half-life, so it doesn't hang around very long. And you don't have that T4 hormone that hangs around for 7 days and can convert. So I do see a lot of people as they dose up, and then they get to maybe T3 only, and they're trying to get off of this high dose T3 because they have now they have anxiousness, anxiety, brain fog, some of the other negatives that go along with high doses of the stuff, and still with compromised physiology, that it can be a really difficult process for them to come down off of the stuff. So yeah, it's tough. Once you get there, if you feel and function good and you decide that, hey, but I don't want to do this, you can go through it. It's a rocky road for a lot of people to get back to more of a normal thyroid chemistry pattern, which is I have T4 that converts to T3 based on what the cells and tissues need or want to do. So I want to talk about reverse T3. I want to talk about deiodinases. And I think one of the places where you and I differ a bit is on this discussion of reverse T3. I think we have different philosophies, maybe I'm wrong, I don't know, but from the questions I get, that maybe we have different take on what reverse T3 means. to you what it means to me. I just was on a podcast and somebody asked me this question. What should reverse T3? What does it mean? How does it work? So let me ask you the same question I got. What is reverse T3? Why do you see it as a problem? And why, when you're talking about trying to lower reverse T3 by giving T3 and maybe less T4, what do you think the impact of that is?
Yeah.
So let's start with the first one. What's reverse T3 to you? How do we get it? Why do you think it's a problem?
So I talk about this on my podcast too. It's a survival mechanism. It's built into our body for a reason. So it's not like reverse T3 is a bad guy, right? It's not bad. It's biologically built into us. And that's why you'll hear your doctor when you ask your doctor, hey, doc, will you test my reverse T3? And they say, oh, we only do that in a clinical setting. Well, yeah, of course, because when you're in the ICU, when you're in the ER, when you're in a trauma state, that reverse T3 is going to go up because, again, built into our body's survival mechanism, it's going to go up to protect your body. At that point of time, your body knows that you don't have to be burning fat. You don't have to be feeling good. You don't have to grow your hair. You don't have to really do any life process that you would normally do. You need to survive. You need to heal. So it's almost like a conservation where the body says, let's shut down metabolic processes so that the body can actually survive and heal. Let's focus on what is injured. Now, we also see reverse T3 go up in pregnancy because, again, you don't need to have a rock star metabolism and be losing weight to step on stage when you're trying to grow a life inside of you. So when we look at the body and where reverse T3 elevates, it's very important to say, like, listen, this isn't a bad thing. Where it becomes a negative to us walking around trying to live life is when reverse T3 is elevated, but we're not in that trauma state. We're not in a clinical setting. And that normally does result from the overproduction, over giving of T4 medication, over medicated people that are given too much T4. That's where we see that reverse T3 go up. Now, I do talk about causes of reverse T3. That's really the main thing because we know that T4 can convert to two different things. It can go down the path and convert to T3, or it can convert to reverse T3. And T4 is the only thing that converts to reverse T3. So in the treatment, in looking at what to do about it, I just had a patient yesterday. His reverse T3 was a 31, and he's not on thyroid medication. So obviously in that case, it's the other things. He's borderline diabetic, low testosterone, high estradiol, high insulin, high A1C, elevated C-reactive protein. I mean, it was all the things that were just glaring on his blood work as to why he had that reverse T3. Now, that's important for the listeners because, see, it wasn't about the T4 medication. It was the other factors that we need to address to lower the reverse T3. Those other factors are putting his body in survival mode and protective mode. That's why he can't lose weight. He's not motivated. He's shutting down. And of course, he also can't lose weight because he's insulin resistant and estrogen dominant and low in testosterone and all the things. So for him, it's not about lowering the T4 because he's not on any. But for patients coming in on large amounts of T4, that's where that change comes in. That's where I say, okay, your allopathic doc has just put you on 150 micrograms of T4. That's pushing way too much to reverse. So let's address the factors that are pushing it that way, that are elevating your reverse, but let's also at the same time, let's pull back. So that's where I do that med change that I talked about in the beginning of let's drop the T4, let's add in a little bit of T3. Most people do well on T4 and T3 only, or T4 and T3 together. I heard a stat from A4M that only 2% do well on T4 monotherapy. 98% of hypothyroid patients do their best and thrive on a T4, T3 combo. Now, whatever that is, it doesn't matter what that is, compounded, armor, Synthroid and Cytomel together, whatever, but some kind of T4, T3 combo. So let's do that. Let's work on driving down the reverse from two different directions so that you're not walking around in survival mode.
So I guess the question would be, because people look at that reverse T3, and I think I was taught this early on, but the literature doesn't support it. That reverse T3 is blocking the T3 from binding to receptors, and that's what's creating the hypothyroid symptoms. And I don't think that's justified in the literature. Most of the reverse T3 is produced at the plasma membrane. And so if we look at the process that the T4 is being deactivated because of an upregulation of deiodinase 3, okay? Let's say that there's inflammatory markers, there's upregulation of deiodinase 3, and you give somebody T4 and you're favoring the deactivation, and you say, well, I'll just decrease the T4, that's going to lower the reverse T3. It will, but the reverse T3, based on the science, doesn't block the receptor. The deiodinase 3 is more of the blocking factor there. So the issue is, if you give T3 and deiodinase 3 is still activated in that cell, you're still going to get deactivation of whatever you give. Deiodinase 3 is still going to deactivate some of the T3 to different form of T2.
Mm-hmm.
There's a couple different forms of T2. I know you're well versed in T2. So my thought process when somebody says reverse T3 is blocking the receptor, that doesn't really happen. That was a nice discussion, and also you hear people say that T3 is a reverse T3 is a mirror image of T3. It isn't. If you look at how the molecule is developed, it's not a reverse. It's not a mirror image. Right. So do you say that reverse T3 is blocking as more of just an easy way to explain it? Yeah. Or do you have some science that I don't see that shows that reverse T3 is binding to those receptors at a high level and blocking it? Because I've read thousands of papers on thyroid physiology at this point, and I've not seen it. I've seen it talked about anecdotally, which happens a lot. I say something, somebody repeats what I say, somebody posts what I said, and that goes down the line. It's like that whisper down the line story. So where do you see that role of reverse T3? Do you feel like it's blocking the receptors, or do you feel like it's just it's an easy way, a simple way to talk to people to say that that's the blocking effect?
The easy way to get people to understand what it does. Like you're right. I have not seen, and I've heard other thyroid experts talk about this as well, not seen enough evidence that there is that true blocking, right? It's not like reverse is covering the receptor site of the cell or something like that. But I do use analogies just to get people to kind of conceptualize and understand better that it's kind of like the bouncer at the club, the bouncer that's standing outside the cell door telling T3, sorry, you're not allowed in. So I do use that analogy just for the ease of understanding. But you're right. It's not, I think, gosh, that would be so interesting. I don't think enough studies are done on the thyroid itself. And as we know, most of them are driven by big pharma saying T4 monotherapy is the best. And all you have to do is check TSH and you're good. So I think that there's a lack of thyroid physiology studies, and it's crazy since it is the master gland. I think we should really be focusing on it instead of giving people all the Band-Aid medications to cover up the symptoms of hypothyroidism. But yeah, like you, I have not seen the hard evidence of reverse T3 blocking the cell.
Yeah. So, and I think it's important. I had that same discussion with Dr. Bianco. He was like, I don't, maybe he's like, I don't know. He didn't really want to get into that piece too much, but he said, I don't think it happens at appreciable levels. And that's primarily what I heard, but it is a thing that's talked about, and that puts a lot of people into focused on driving down their reverse T3. And they think the way to do that is take less T4 and take more T3. Absolutely. You will lower your reverse T3 if you don't take T4 medication, but T4 does have a significance and it does have an importance to it. There's a reason why the body doesn't just only make T3. There's reasons for it. So we got that part covered. I think the next thing it's important to discuss is when you do give somebody T3 and they feel better, at least temporarily, and there's elevated deiodinase 3 potentially due to immune inflammatory cell defense mechanisms going on, why might they feel better?
Well, you're skipping the middleman. You're giving them that active thyroid hormone because we know that T3 is active, T4 is inactive. So T3 is what all our receptor sites on the cell, that's for T3. It's not for T4. So you give the T3, you do skip the middleman. Now, I will say though, I do, when we give that T3, when we actually get them to that sweet spot optimized level where they're feeling great, most of the time they stay on that dose and continue. As I track my patients through the years, they continue feeling great on that. There's very little changes that we have to do. Now, of course, life will happen, right? Stress will happen, infections, whatever, that will happen to create inflammation in the body. And there might be some changes that we have to do. But for the most part, you find that sweet spot, you find that sweet dose, and you can really kind of coast on that for a while. So I can't argue with the fact, again, going back anecdotally, I can't argue with all of these people saying, I am better. I suffered for years and now I am better. Now, is it the combination of everything? Of course. Yes. Because again, I could give you a boatload of T3. And if you're hitting the McDonald's and you're sitting on your couch and you're not moving and your hormones are out of whack, then no, it's not going to work. I'm not saying that it's just all about thyroid medication, thyroid hormone replacement. Yeah, I'm a fan of T3 because I do like skipping that middleman. And I know what it's like to be on T4 only. I've seen too many patients come through the door suffering for decades and nobody's listening to them. Nobody's testing the reverse. Nobody will give them 5 micrograms of T3 to save their life. And you start doing that. And it's like, oh, this whole burden lifts, the lights come on, the fog lifts. I mean, you can't argue with that. And then for them to continue feeling good, I can't argue with that either. So absolutely, I want to find that underlying cause. I want to treat the infections. I want to treat the inflammation. I want to treat all the things, but I want that person feeling good, because 6 months down the road, if they're still feeling like crap, it's coming back on me. And I'm like, well, you didn't do anything for me. Like, okay, we did this too slow. I see. Well, let's give you some T3 so you feel better. And let's get you to that optimized sweet spot.
So I'll kind of throw my 2 cents into why that might occur. I think sometimes we think there's an on-off switch, that you're either not converting or you are converting. And that's not the reality of the cell. It's a down regulation. Even in an inflammatory state, there's still deiodinase 2 activation, but the deiodinase 3 is ramped up. So you're going to get more, but you're still getting T4 to T3 conversion. You're still getting other factors going on. T3 can get deactivated too, but there's forms of T2, which you well know, that can still support backup function and physiology. So there's thyroid metabolites that still have thyromimetic effects, even though they're not the primary T3 hormone. And I think that's where a big piece is. I think sometimes we think about it's either all on or all off, and that's not the way the physiology works. I think the way that it typically works is that when there's a cell stress response, we're reducing the conversion of T4 to T3. We're deactivating some of that T3 to some inactive T2 metabolites and other metabolic pathways as well. But there's still enough there as to run as a backup, because we still need to generate energy. We still need things to occur, and getting some, even if T3 is being deactivated, I'm still getting enough to do some of the basic primary functions. I'm getting some of the T2 that can still support the mitochondria to some degree. It's not all or none. So I think that's where some of that benefit comes from. I explain to my patients like a backup generator. Like if the power goes out, which happened to us this week with the big storms, if the power goes out, I don't want to be in no electric. So I get the old gas generator out and I plug it in and I can run the refrigerator, and that's about it, right? And so if I want to get a hot shower, I got to unplug the refrigerator and I could do some things. So I still have some basic cellular function, because if you don't have thyroid hormone at all, you've got little to no cellular function going on, and that you're not going to survive. Mm-hmm. So I think that's probably a big role. We've got these other things that we don't fully understand, things like the downstream metabolites of T3, T2, and even the things, the thyroxamines that are there that may have some things that have a positive effect, maybe some things that have a negative effect. I don't think we fully understand it, but I think it's some of those downstream metabolites that can still support us maybe in a backup function, even when we have this immune inflammatory processes going on. So that to me would be the most likely reason why.
And believe
we
me, I mean,
think,
I would love to take T4. I would love to have some savings account, right? Some backup, the backup generator. I would love to. And I talk about the importance of it all the time. And I've had this discussion with, you know, I know you were on Karen Martell's. We've talked to El Russ, like the three of us have discussed. I would love to take T4, but I can't. Every time I try, it results in a decreased quality of life significantly. So yes, to your point, it is best to have that backup. It is best to have a savings account of T4. That's the optimal way to go. It's not, I don't want anyone to think it's a goal to be T3 only, or that it's a goal to be on more T3 than T4. It's not. It really isn't, but it is about finding what's for you. Now, I think with the bioregulators, I don't know if you've talked about this on your podcast yet or not, but going down that rabbit hole and studying those, maybe, I mean, it looks very potential. I'm a huge fan of peptides. So these bioregulators coming out, the thyroid bioregulators, looks pretty sweet to actually restore thyroid function. And then maybe we can get people off thyroid medication, lower their thyroid medication, actually restore proper thyroid function, whether they're hypo or hyper, with these bioregulators. So that kind of looks promising as well.
we're talking about two different things, right? You're talking about supporting the thyroid gland versus the cellular conversion, right? And that's the big thing, right? Is the big issue the big issue that the gland just doesn't work? Or is the issue is that I have poor conversion?
Right.
And in my mind, I think that at least at the onset, hypothyroidism isn't starting at the gland. Hypothyroidism starts long before the gland becomes dysfunctional. So I think when you have the person who's coming in, I'm tired and fatigued, I've got glucose resistance, I'm gaining weight, that person already has cellular or tissue hypothyroidism going on. It's already present. The question becomes, in allopathic medicine, they're not going to do anything about that because their gland is still functioning. They only have one or two tools in their toolbox. And so if there's enough T4 in the system that the TSH is showing it's appropriate, they're probably not going to jump in. But that's really our wheelhouse in functional medicine, is to be able to try and catch those things early. But we have a glandular issue, we have a tissue issue, and those two things, if you have glandular hypothyroidism and there's no replacement, you're going to have tissue hypothyroidism. But you can have a perfectly functioning thyroid gland and have tissue hypothyroidism. You can have appropriately optimized T4 and T3 in the bloodstream, but still have tissues that are struggling either with hypothyroidism or hyperthyroidism because they're over functioning or overstimulated. So I think that's kind of a nuanced thing. And I think, in everybody's situation, like even in your situation, if you feel and function well on T3 and you feel like, hey, this is as good as it gets, right? Then what you're doing is probably appropriate. But I think one of the things is when you're that's a situation where you're not asking that thyroid gland to do work, right?
Right.
That's why so you've shut that system down. You're like, hey, that thing's not working well for me. I'm doing this and I feel and function well on it. I don't think that's that's not the point for argument or discussion as much. If that works for you, that's great. The issue is more for the person who's on that journey, who's trying to find T4 didn't work, T4, T3, I'm up and down with that. Then I tried higher and higher dose T3. I optimize my blood values. I still don't feel well. And their goal is to not take all that take medication. That's where we dig in and we start to say, okay, there's no way that gland is ever going to have a chance to recover if you're taking a day's worth or more of thyroid medication and that you're suppressing that TSH, because there's no drive for function at that gland. So, but it's really based on the individual and what their goals are. So that's that bio-individual medicine thing that we talk about. Like, what is your goal? What is your objective? What are you happy with? And then we develop our strategy around those things. And still, want to optimize, even if you take T3, if you're saying, listen, I'm taking enough T3 to run the system, if you didn't address all the other things, you're still going to upregulate your brain and you're still going to have downregulation in the periphery. So you still have to address the right things, whether you take medication or you don't want to be taking medication, you still have to address the foundational things, right?
Mm-hmm. Yep, absolutely.
So I want to go through, this might be a little bit controversial. Maybe we talk about it more on another discussion, but there's the discussion about the immune system, and there's the take that the immune system, I'll do like coming a rapid fire here. So some people say the immune system is out of control. This would be more the allopathic approach for sure, but your immune system's out of control. There's nothing you can do about it. It's going to destroy your gland. Therefore, you're going to always need medication. Do you look at the immune system as being out of control, or do you look at it as more of an adaptive, protective piece of physiology?
Yeah, no, I would say more adaptive. So of course you have those autoimmune balls of fire, right? You have those people that mom had Hashi and Graham has MS and they already have, whatever, three other types of autoimmune. You see that genetic predisposition just permeate a family. You see it just go all the way down. So obviously there's that genetic component of autoimmune. But at the same time, no, I don't think that it's something, I think it's something to be supported. I think we have to nurture the immune system. We have to retrain it. We have to teach it that the thyroid gland or your whatever it's attacking, your pancreas for type 1 diabetes, your skin for psoriasis, whatever it's deciding to attack, we have to reassure it that everything is okay. And we have to calm that down. And then when you calm that down, when you decrease the inflammation, when you basically put the body in a safe space, then those soldiers that are going out and attacking, they chill out. They go back in their barracks. They go in their bunks. They take a rest. Everybody's calmed down. So that's what I believe with the immune system is that we absolutely can treat it. We can stop that fire, that attack, that war that is going on in some people.
Yeah, I think it's likely, at least in the beginning, more of an adaptive response than broken physiology. And I think when we tell people your immune system is attacking you for no apparent reason, and you're doomed, that's hard to get somebody better from that situation. And I think it's a really bad attitude for somebody to say, I have my immune system is attacking me. There's no way that person's going to have an easy time getting healthy and get well because they're looking at their body doing the wrong thing versus it's an adaptive response. If from my perspective, if I've got a chronic infection, am I going to upregulate the metabolism? Am I bringing more glucose and minerals and amino acids into a cell that has a bacteria or a virus? Probably not. There's an adaptive response. If I bring more resources in, then that organism, that threat, can use those same resources to support itself. So if you look at the works of Robert Navio and others on these cell danger mechanisms, it's more likely that a lot of what we see is probably adaptive.
Yeah,
second,
absolutely
kind of rapid fire question.
Yeah.
There's an opinion in functional medicine about thyroid antibodies. One opinion is that you need to suppress the antibodies because the antibodies are little Pac-Men that are eating away your thyroid gland. The other is that the antibodies really may not have as much significance as we give them credit for, and that people put less, they watch them, but they put less concern on them. Where's your opinion and thought process regarding thyroglobulin antibodies, TPO antibodies?
Mm-hmm. I'm glad you asked that. So I always tell people, don't hang your hat on your antibodies. Okay, here's the thing. I have seen people with insane amounts of antibodies, especially the last couple of years, like 3,000, right? I mean, really off the charts. And then I've seen people with 100, 200, whatever. And I also see these patients hyper-focused on that number. and they just want to drive that number down. And I go, well, while that's a goal, because, you'll have people talk about Hashimoto's going into remission, putting Hashi into remission by lowering the antibodies to zero. Okay, I get that, because if they are soldiers, if they're Pac-Man, like you said, sure, if they're at zero, then the destruction stops. But what people don't understand, and what I try to teach them, is those antibodies can fluctuate. Maybe you did just have a viral infection. Maybe you had an uptick of your Epstein-Barr virus that pretty much we all have dormant in our system. Maybe something happened. Maybe you were under a lot of stress, and that just kicked up those antibodies. That doesn't mean that you're not well anymore. I don't want you to look at those antibodies and go, well, I must not be optimized. I must feel like garbage because I have antibodies. Like, no, you could be, it all comes back to, how do you feel? So that's what I'll ask them. I was like, I can show you a patient with 100, 200, 500 antibodies, but they feel like a rock star because everything is well in their world. We have balanced everything out. They're doing the lifestyle, they're doing the nutrition, they have the right medication, they have the right replacement coming in. And I can show you somebody with zero antibodies that feels like garbage. It's because they're not doing all the other things. So who cares that they have zero antibodies? They're a mess anyways that we have to address. So that's my take on antibodies. I am not hyper focused on them at all. It's okay. It's information. It's data. If somebody shoots up to 3,000, I scratch my head. I go, okay, well, what happened here? What were you exposed to? But yeah, without going, too far down that CV rabbit hole, what were you exposed to? I've seen that in my practice, but I don't hang my hat on the antibodies.
Yeah, I think the literature is pretty clear at this point. The thyroglobulin antibodies create no damage to the thyroid gland at all. And the TPO antibodies, based on some of the more recent papers, probably cause very little damage. So what's the difference then between thyroiditis driving hypothyroidism and Hashimoto's thyroiditis, right? I would argue there is no difference except what side of the T system is upregulated. I don't know if you run Cyrex's lymphocyte map test, but I've run lots of them.
Okay.
And when you look at patients who have diagnosed with hypothyroidism, most of the patients, I would say 70 to 80% of the clients who have been diagnosed with hypothyroidism are Th1 dominant when they're in their acute state. If they're in their Th1 dominant system, they're likely to have less antibody production. So I tell people, listen, if you have thyroiditis and you're not iodine deficient, you still have Hashimoto's. You have an immune-driven thyroid damage. Now, the argument is it protective or it's caused by some trigger and it's a cross-reactivity? That's a whole nother discussion. But it's not the antibodies creating the damage based on the more common research. So they're important to look at. I agree. You look at the antibodies to kind of say, hey, is there a lot of potential damage going on? But you can't hang your hat on, because there's antibodies that's problematic. Thyroglobulin antibodies don't cause any damage to the gland, then why are they there? It may just be the T2 system is upregulated. It might be that there was some damage to the gland and the thyroglobulin is spilling out and there's a cleanup process going on. But I don't think we should hang our hat on it. But I would tell most people, they're like, well, I have hypothyroidism, but I don't have Hashimoto's. If you're not iodine deficient and you have hypothyroidism, you have thyroiditis. The antibodies, and I don't know if you've seen this, but as you start to work on these people, if they didn't have antibodies and they're like, hey, I'm feeling better, I'm functioning better, my thyroid hormone dose is going down, I'm converting better, they're feeling and functioning better. Now, all of a sudden, they start to have some antibodies. They're like, oh my gosh, now I have antibodies. Yeah, because your immune system is starting to balance itself back out. We're not worried about that. No, if it's greater than 4,000, then we have maybe a different concern that we swung the immune system too far in the opposite direction. But I tell people all the time, listen, as you start to feel and function better and your immune system starts to balance out, you might start to see some antibodies. We're not going to panic. We're just going to take a look at all the rest of the cellular physiology and see what it looks like. So I had one more I don't think we have time. So we got about 6 minutes. I want to give you some time to let people know where to find you. There's a lot of other questions to discuss and talk about it maybe another time. Blood glucose regulation, adrenal physiology, and maybe we'll talk about those things when I'm on your podcast. But
Yeah.
if you had to leave people with 3 pieces of advice of where to start, everybody wants to start with the magic supplement, thyroid medication to normalize or optimize their blood values. And if you think that that's one of the top 3, then say it. But you got a new person in, they're struggling with chronic health issues, diagnosed with hypothyroidism, they feel like crap, on medication, still don't feel well, maybe not on medication. What are the 3 initial things that somebody can do or should be doing that doesn't require you or me, because they got to do these things anyway? What are the 3 foundational things you tell almost everybody they got to start doing?
Okay. Yeah. That doesn't require you or me. That's the key. So number one, and we didn't go down this rabbit hole, but I do love how you talk about insulin resistance as glucose resistance. I mean,
I hate the term insulin resistance. Hate
yeah,
it.
I know. I just naturally use it. But when I heard you say glucose resistance, I'm like, oh, that's a good one. I like that. So, but that's a big thing. That's huge in terms of inflammation. I mean, we even know now that Alzheimer's that my mom battled. Oh my gosh, it's the worst thing in the world. That is type 3 diabetes, high insulin, high glucose, or dysregulated glucose, dysregulated blood sugar is a huge driver of inflammation, full body inflammation. It will shut down your brain. It will cause weight gain. Obviously, we know that. But the inflammatory effect on the body, the stress on the body of having dysregulated blood glucose is huge. And that, I think, really, really affects the thyroid gland, really affects thyroid hormone production, affects every single cell. So if we do get down at the cell level of T4 to T3 conversion, of T3 activation on the cell, lower your insulin, control your blood glucose, do those dietary changes, eliminate the processed foods. I know, blah, blah, blah. You've heard this a million times before, to change your diet, eliminate the processed foods, but for goodness sake, you got to do it. You got to do it. And I don't think it's a ketogenic diet. I don't think it's a carnivore diet. I think it's just change your habits, because we know that even lack of sleep. So I guess that would be number 2. When you start looking at sleep studies, I mean, I don't even like to look at them, because then if I get a bad night's sleep, it's all in my head, right? You start looking at your circadian rhythm and the importance of sleep. It is huge. And that is one that I keep pounding into my patients and my audience's head is, please don't come to me and say, well, I can't lose weight, I'm not feeling better, and I'm still fatigued, and you're going to bed at 1 a.m. or midnight, and you're not sleeping well, and you're eating your air popper popcorn before bed, and you're all jacking up, again, your blood sugar, which is going to affect sleep. Sleep is so important. So control your glucose. You got to get sleep, because even just getting a few nights, well, actually 1 night of bad sleep is enough to dysregulate your glucose. That's why you're hungry the next day when you only get 5 hours of sleep, or when you rolled into bed at 1 or 2 a.m. because you missed out on that rest, repair, restore time. You screwed up your whole circadian rhythm, and you will absolutely dysregulate your glucose control. So that would be number 2. Number 3, I am going to throw in a supplement, but it's going to be the iodine thing. And that could be a whole other podcast that we could do. And I'm going to ask you that on my podcast, your opinion on iodine. I really think it's simple. You don't have to overdo it. It supports the entire body. Every cell in the body needs iodine. It helps support conversion. It really helps support the thyroid gland itself. It helps support the immune system. It's antiviral. I mean, fibrocystic breast disease, we can see that go down. We can see, I give it to my dog even. I mean, just an upregulation of the cell. I mean, just an improvement in the entire body with iodine. And I just think that it's such a simple supplement that everybody can add in. And then again, I mean, yeah, that can open up a whole nother door of discussion, but those would be my top 3.
Yeah. So for the first one, for glucose regulation, I think this is where some people get really frustrated. And I think what you're saying, and correct me if you're wrong, if you're following healthy whole food, mild to moderate carbohydrate diet, and I'll just my suggestion for most people, simple macros, right? You can't undercalorize and expect you're going to be healthy long term. Okay? I know everybody who's overweight wants to restrict their calories, and that's going to be beneficial. It also becomes problematic. But from a caloric standpoint, I like almost a 40-30-30 ratio as a general kind of across the board for most people: protein, carbs, and fats. And then you work off from there. But simple math, about a gram of protein per pound of body weight, what you think is your optimal body weight. Okay.
Yep. Yep.
But if your glucose is elevated, you're glucose resistant, you have higher insulin, you have a higher hemoglobin A1C, please keep in mind that there's these two things go in hand in hand. If you have low levels of T3 inside your cells and tissues, you're not going to be able to take food energy, glucose, and convert it into cellular energy at a high rate. So you can't utilize a lot of glucose. So therefore, you're going to be a little bit more glucose resistant because you don't have the ability to push as much stuff through. Is the downregulation of the mitochondria, is that adaptive or problematic? That's maybe a discussion for you. I think the downregulation is adaptive, and I can talk about why. But if you're doing a lower carbohydrate diet and you're still glucose resistant, that is a great indicator that you've got some level of tissue hypothyroidism, because you can't get the glucose into the tissues appropriately. So I think what Dr. Amie is saying is, if you are eating a lot of processed food and a really high unhealthy carbohydrate level, and you're outside that 40-30-30 ratio, get into that ratio, right? Is that fair to say?
Absolutely.
But if you're the person who's in that ratio, some people jump to keto and go, well, if I can't use glucose, then I'll go to keto. And then they find that, yeah, they may have their initial focus where they feel a little bit better. And then they're like, well, I can't lose on keto either. Yeah, knock. If you don't have enough T3 in your cell to run your mitochondria, you're not burning fat as a fuel. And so now you're going to be breaking muscle tissue down to make glucose, and you're going to jack potentially in the short run, jack some cortisol, but you're going to jack epinephrine levels, because you got to generate more glucose, because you can't do it, not bringing it in from diet. And you can't break the fats down and use them efficiently in the mitochondria through beta oxidation. So I totally agree that we got to watch what we're consuming. And that's a great place to start. The second one, I think you said, was sleep. And this was a big problem for me. 4 hours of sleep, even though it was a badge of courage, like, I'll sleep when I'm dead.
Yep.
It's a terrible strategy long term. You can get away with it for a short period of time. For 2, 3, 4 decades of my life, I got away with it. But you start to add that up with excessive training, limited sleep, poor breathing because of deviated septum. This shit's coming home to roost at some point, and you can't look at sleep as weakness. That's when your body heals and repairs. There's so much that's going on. And so if you have terrible sleep habits, fix them.
Yeah.
Fix them. You don't need me or Amie to help tell you, hey, go to bed to sleep, turn your Wi-Fi off, turn these things off, right? Breathe through your nose when you're sleeping, tape your mouth shut, right? All these things, you can do those on your own. If you're doing all those things and you still don't feel and function well, and you're still having a hard time sleeping, even though you're doing those things right, that's definitely the time to bring in a good functional medicine practitioner who can say, listen, the reason you're not sleeping well is because you don't regulate blood sugar well. And now your body at night is upregulating some of the emergency defense to make glucose, because the glucagon's not doing it enough. I need cortisol, or I need epinephrine. And a lot of times it's epinephrine.
Yep.
And then the third one is supplementationally. I think iodine, and before everybody runs out and starts buying a bunch of iodine, it's not what she's saying, but a healthy level of iodine is important. You're going to hear in thyroid world, there's one camp that is nobody should be on iodine. Everybody's overloaded. There's another camp that everybody should be doing high dose iodine. There's a group in a thought process that if you have TPO antibodies, that's causing your thyroiditis. I don't know that I'm in any one of those camps. I think that we all need iodine. I agree. Iodine plays a significantly important role in our physiology. We don't have a great way of assessing it or testing it, that we have clear evidence that this is the best way to measure it, but there are ways to assess it and evaluate it. I think you don't have to live in iodine fear. I don't think that's a great strategy, but I don't think everybody
Right.
should be over supplementing with copious doses of iodine either. But we do live in this
Exactly.
iodine fear if you have TPO antibodies, like, oh my gosh, you cannot do that. And I don't think that's justified. So
No,
I think we
I
got those
agree.
questions done. I know we wanted to have maybe a longer conversation on T2. That'll have to be saved for another day, but we did about an hour and a half, which is about what we typically do on my podcast. I think it was a good conversation to have. We kind of hashed out some of the things that maybe people, when they listen to your podcast or my podcast, might say, wow, these two people are like opposite or totally opposing views. But now when we have the discussion, maybe our views aren't that opposed. We just have
Right.
different strategies for how to address what we're trying to accomplish. And I think at the root, we still have the basic concepts of functional medicine in play, which is you have to raise your level of, I call them fitness factors. So you have to raise your level of fitness in different categories of your life: physical fitness, emotional fitness, respiratory fitness, sleep fitness, microbial fitness, environmental fitness, habitual fitness. Like, you have to raise those things. There isn't enough supplements in the world or enough thyroid hormone or sex hormone replacement therapy to fix you, to optimize you if you don't address those things. Could you feel different? Absolutely. That's why they make drugs. But if your goal is to be healthy and have a better state of health as you progress, because we can live 80 years, but if you want to live 80 or 90 years, you want them to be high quality years like it used to be, that your illness was the last 5 to 10 years of your life, not the last 40 or 50 years of your life. So the foundational things become really important. So, Amie, I appreciate you coming on. Do me a favor, tell everybody where they can get more information about you. I know you have a podcast. Let them know about your podcast, your website, and whatever else you have going on.
Absolutely. Thank you so much. Yeah, Dr. Eric, you're going to be on my podcast, the Thyroid Fixer podcast. And then you can also find me at dramiehornaman.com. And on Facebook, I have a Girl Fixer Thyroid Facebook group where you guys can jump in and ask these questions and get a ton of support from myself, my team, my coaches, and then even my patients and thyroid people. I mean, they're in there supporting you. So that's a great place to join and get more answers as well. So thank you so much for having me on, Dr. Eric.
Awesome. So for everybody who's listened, share this one with your friends and family. Maybe go back and listen to it a couple times. Understand some of the things we talked about, because I think sometimes we hear snippets of things and then take that to our physicians and say, hey, this is what this person said. And maybe listening a couple times to a discussion like this, you start to say, okay, I thought I heard that, but that's not really what I heard. And here's what I really need to be doing or should be doing. And all the things that we talk about, we talk through this lens of thyroid physiology, but I think Dr. Amie and I would both agree that's just a tool to get you to listen, to do all the things about raising your fitness factors. So you're never going to be well if you're just trying to manipulate thyroid physiology. You have to look at all those other things. So Amie, thanks so much for coming on the podcast. It was great having you come on. I look forward to showing up for your podcast as well.